Hello, I'm very happy to be speaking at this conference, and I'm very sad I cannot be on site, but I look forward to coming next time. My name is Marc AURIACOMBE. I work at the University of Bordeaux in Bordeaux, France, and I'm also a clinician at the University Hospital in Bordeaux, France. My presentation will address the issue will be in the field of addiction and address new data, new research from the University of Bordeaux and others that have very, very important implications for treatment of addiction and collaboration with patients. The title of my presentation is Addiction from Use to Use Disorder and Craving, Craving for Diagnosis, Prognosis, and Treatment. I will address the following four major points: current status of craving in substance use disorder, evidence that craving contributes to prognosis, how to characterize and measure craving, and implications for treatment. At the end, I will also give you links and references for further reading. First, let's examine the current status of craving in substance use disorder, craving as a diagnostic criteria. By the way, what is craving? How is it defined? What is addiction, How is it defined? Or sometimes called use disorder, substance or non-substance use disorder. Addiction is not just about using, even a lot. It is impaired use, impaired control over use. When examining the current individual diagnostic criteria of the DSM-5 that were published in 2013, there are several important points to keep in mind. One is that addiction is a long-lasting condition. It is a chronic disease. And currently, we need time to be sure that this chronic condition exists. This is why you need to document over a year that there have been persistent problems to determine that there is addiction. Then you have core criteria that describe loss of control, to which craving has been added. And then you have more consequential criteria, consequential of the loss of control, and that are complications, negative outcomes of impaired control or loss of control. Craving was added as a diagnostic criteria because of its specific psychometric qualities. On this slide, you have data from the University of Bordeaux, but that replicates previous data from other groups, especially University of Columbia, that show that craving is among the criteria that are the most frequent, that are present in almost all patients, and that are the most discriminant, the most characteristic of addiction. And this is why it was added as a diagnostic criteria. So this allows us to have a clearer picture of addiction with what is central, loss of control, characterized by relapse and craving, that needs to be distinguished from causes, pre-existing factors, and risk factors for addiction that will persist once there is addiction, and the consequences of loss of control, which is excessive use, intoxication, withdrawal, impairment, and toxic effects that are consequences of addiction. It is paramount to differentiate addiction and loss of control from its pre-existing factors and from its consequences. And this is very important for treatment targeting. What is the evidence that craving contributes to prognosis? Because indeed, it is one thing to document that craving helps to diagnose. It is another thing to assess that craving and its change over time predicts outcome and relapse. For many decades, craving has been reported as something that many individuals with addiction complain of. But there was debate among health professionals and researchers about whether craving is a cause to relapse or a consequence to relapse. A bit a chicken and egg issue. One of these issues was also related to the difficulty. This has allowed to resolve the issue of whether craving is a consequence or a cause to relapse. Craving, when it exists, predicts an overall risk of relapse over the next 3 months. But craving, when it is assessed in the patient's daily life from hour to hour, changes, goes up and down, and these changes predict use over the following hours. This data has been found at the University of Bordeaux, but also in many other universities now, and allows to determine, to model things as craving. The craving use relation is a dose variation response intensity. The more craving increases, the higher the probability of use. And conversely, very important for treatment, the more craving decreases, the higher likelihood the patient will stay abstinent. This allows us to have a simplified understanding of things, with craving predicting relapse for many substance addictions, but also for gambling and food addiction. So craving is a unique criteria because it has an etiological characteristic, as it is able to predict use and relapse. This gives us an opportunity to make it simple. And many times in the past, in the area of addictions, things have been overcomplicated, making it difficult for health professionals, for patients, and for their families. We can modelize addiction as a disease, a disorder, with an objective phenomenon, an objective sign, which is relapse, unwanted relapse. So reusing in a non-voluntary way with repeated negative consequences. and a predictor symptom with etiological characteristic, craving, which precedes and predicts by its changes over time, use and relapse. Now the issue is, knowing that craving is so important, how to characterize and measure craving, which is a unique individual experience. But before that, we need to clarify some definition about what is craving. Craving is not just an intense desire or urge. And here we need to be careful about language issue. Craving is an ordinary word in the English language. When I use the word craving in this presentation, I'm not meaning the ordinary word. I am meaning something specific to addiction. Craving is a term we use in French to characterize this unique experience that people with addiction have. The English for craving would be something like unwanted wanting. Craving is not just wanting very intensely. It's wanting, although at that moment you actually do not want to want. So craving is complex, and it needs to be distinguished from withdrawal, from intoxication, from depression, from anxiety, all of which are very frequent in people with addictions, including delusions and lack of motivation. Craving is a subjective, individual experience. It expresses itself as a desire or an urge, but it is focused on a specific object that can be a substance, alcohol, tobacco, cannabis, heroin, or a behavior, gambling, or food. It is focused on something that has positive reinforcement, that is an object that will give its user pleasure. It fluctuates, and this makes it very tricky for patients at the beginning. Craving goes up and down. It's very intense, very disturbing, and then it disappears after 10, 20, 30 minutes. At some point in time, over a day, over several days, over a week, it can become overwhelming, uncontrollable. It has this unwanted flavor, which makes it difficult for patients at the beginning to find words to explain to their family, friends, or their doctor what is happening to them. Its expression can be physical or very emotional. So craving is complex and difficult to measure from a qualitative perspective. However, in clinical individual practice, what the research shows is that what is important is not that the patient has craving or not, but that craving changes over time. So it's the variation in intensity of craving that is going to be important, that is of interest. And this actually, a bit like for anxiety disorders or for disorders with pain, can be simple to measure with a visual analog scale. And the patient at any given time can self-assess the intensity of his craving at that time. craving scales is a challenge. There are many scales, and there is a multidimensional aspect in craving. There's an urge aspect, a desire aspect, a relief aspect, an intention aspect, many aspects that can be individually studied. But the issue is that it has a unidimensional aspect to it, very individualized by patient, and it is going to be important for the clinician to help the patient to characterize his craving and how it fluctuates over time and how it is different from his emotional state, his intoxication, his withdrawal symptoms. So we can make things simple, but we need to keep complexity in mind. The simple model, what we know now, is that use and relapse in case of addiction is predicted, mediated by craving. Is craving the only mediator for use and relapse is not demonstrated. However, craving is the best documented mediator for use and relapse. In addition, if craving changes sometimes for no reasons, there is also plenty of data that show that craving can also be influenced by environmental cues, and this is well known, but also individual cues unique to each patient. More recent data have contributed to explain why sometimes craving is difficult to assess. And why also patients and clinicians have wrong ideas about craving. Craving has many consequences, two of which are it predicts use and relapse, but craving, because it is a disturbing negative experience, will produce symptoms consequential to craving, such as negative affect, anxiety, and depression. These symptoms consequential to craving are not associated to increased use and relapse. It is uniquely craving that predicts use and relapse, not collateral anxiety and depression. So many patients who are not able to describe craving will describe the consequence of craving, and they will say, oh, I use because I am anxious, because I'm depressed. And if the clinician treats anxiety and depression and not craving, the patient will still relapse. Now, what happens in case of associated mood and anxiety disorder, which is frequent among people with addiction? Of course, in case of a coexisting mood and anxiety disorder in someone that also has an addiction, there will be increased anxiety and depressive symptoms. Yet the data show that these do not influence use and relapse. However, in case of coexisting mood and anxiety disorder, there will be more craving, and as a consequence of more craving, there will be more use and relapse. So the old clinical observation that people with an addiction and a co-occurring anxiety or depressive disorder are more severe is correct. The addiction is more severe, and there is a need for more treatment of addiction, in addition, of course, to the treatment of the mood and anxiety disorder. However, not all the increased use and relapse is explained by increased craving in case of co-occurring mood and anxiety disorder. there is some use and relapse that is directly consequential to the condition of having mood and anxiety disorder. And this is what is so-called self-medication hypothesis. But it is not mediated by the quantity of anxiety and depressive symptoms. What are the implications of all these new research for the treatment of addiction? Before that, we need to keep, again, complexity in mind, and that addiction is not the only reason for using. Each time someone has used substances or practiced addictive behaviors and has had negative consequences, it does not mean that he has an addiction. We need to assess four major components. One is the context, the environment, where the patient is. The environment of an individual is a very strong predictor of use without addiction. Once someone has addiction, the influence of the environment is much decreased, which is going to be a problem for the patient and his environment that will not understand why he is not behaving appropriately. Another condition that will influence use is medical conditions with pain. We know today that all substances and behaviors that contribute to addiction relieve pain, not just opioids, but smoking tobacco decreases pain, drinking alcohol decreases pain, gambling decreases pain, eating decreases pain. So someone with a medical condition with pain will overuse without necessarily having an addiction. Another condition that influences use are psychiatric disorders. Psychiatric disorders produce symptoms such as delusion, anxiety, depression, and these individual symptoms can be alleviated by many substances such as alcohol, tobacco, opioids, cannabis. So someone with a psychiatric disorder that is not diagnosed is likely to self-medicate by using substances. And this may give the impression he has an addiction while he may not. Finally, what characterizes addiction, independently of having a psychiatric disorder, a medical condition with pain, or of the environment where the individual is disorganized use, dysregulated use, loss of control, where craving, wanting, instead of appearing in the appropriate moments related to the environment where I am, will come up in inappropriate situations. And this is where the person with an addiction will have many problems, regardless of its motivation for use or not using. This is a major potential for change in the treatment perspective of addiction disorders. There should be no condition for treatment access other than the clarified diagnosis. Once the doubt on the diagnosis of addiction is cleared, access to treatment should be unconditional, and patients should not be asked whether they want abstinence or reduced use, or their motivation should be examined on an a priori basis. Access to treatment is paramount. We now have a clarified objective for treatment. The goal of treatment is to modify the relapse rate and its intensity. Not to ask the patient to be abstinent. He cannot because of impaired control. So we want to modify intensity and rate of relapse. And for that, we have a target now, which is craving. Craving needs to be assessed, monitored. The patient needs to be educated to self-monitoring craving, which will allow him to modify craving and so to modify the probability of use and relapse. Hence, abstinence or use reductions are going to be consequences of treatment. They will be assessed after a certain period of treatment. And it is health professionals and therapists' responsibility to achieve that goal, not the patient by himself. And this strongly contributes to patient destigmatization and increased empowerment. We now have clarified goals for medications, psychotherapy, patient education, and empowerment. The primary goal should be to avoid relapse through management and reduction of craving. The secondary goals are to minimize the consequences, withdrawal symptoms, adverse events. As you realize, this is a major shift compared to what was done previously, where we were mainly focused on consequences of addiction, so more on the toxicological consequences of addiction, and not on what drives the addictive behavior. So treatment should focus on craving, not withdrawal. To conclude, craving is the future of addiction. Thank you very much for listening. Again, I'm sorry I cannot interact with you to answer questions, but feel free to ask me questions by email, and I will take time to answer your questions. And you can have further readings with the links here that you should be able to click to access to further documents accessible on the internet. Thank you very much.